Thank you very much. Good morning to everybody. I would like also to thank the organizers for inviting me to speak to your meeting. And on behalf of the Endocrine Society of Cyprus, I would like also to welcome you all to our beautiful island and wish you a pleasant stay. My topic is subclinical hypothyroidism and clinical implications, and I would like to start saying that some experts feel that the term subclinical hypothyroidism is misleading because it suggests that it is clinically unimportant. On the other hand, other experts are more skeptical about the clinical significance of subclinical hypothyroidism because the evidence on screening and the benefits risks of treatment are still controversial. We may call subclinical hypothyroidism mild hypothyroidism because it is often asymptomatic, but some patients have some non-specific symptoms, and we see this every day in our offices. The prevalence in the general population is about 4 to 10%, and we see a 20% prevalence in the elderly women. Most often affected are women and the elderly. So, subclinical hypothyroidism, from now on I'm going to call it the SCH, exists when the serum TSH is above normal in association with normal serum thyroid hormone levels, and that can be the total T4, free T4, or FTI. And usually the elevated TSH is up to 10 MIU per liter, and that represents about the 80% of people with SCH. The other 20% may have higher numbers of TSH. In about 60 to 80% of the patients have positive anti-TPO antibodies, and they may also have ultrasound changes. So who's at risk for developing SCH? As I said at the beginning, women, especially over the age of 60 years old, people with autoimmune disease like type 1 diabetes, people with pernicious anemia or rheumatoid arthritis, people with a prior history of hyperthyroidism, history of head, neck radiotherapy, or people using lithium or amiodarone. Before justifying the diagnosis of SCH, you have to exclude other causes of elevated TSH that don't have any thyroid pathology. And these are CQ thyroid syndrome, obesity, adrenal insufficiency, TSH assay problem, like the presence of heterophil antibodies, medications, like amiodarone, lithium, tyrosine kinase inhibitors, chronic renal failure, central hypothyroidism, and mutations leading to inactivation of the TSH receptor. But it's very important to know what is a normal TSH. Our colleague before described the measurement of TSH. We consider as normal TSH in most labs the range between 0.5 and 5 MIU per liter, and this is derived from cross-sectional population studies. We know that it follows a bell-shaped curve, the distribution of the normal TSH, and that we have higher TSH in older people and in whites compared to young and blacks. In subclinical hypothyroidism, we see that a small decrease in the free T4 level can lead to a large increase in TSH. And this is shown here as well in this graph. As we move from the euthyroid phase to the mild thyroid failure, we see that the TSH is elevated more compared to the free T4 or the free T3. And what is the natural course and progression of this problem? We have a 2 to 6% average yearly progression rate to overt hypothyroidism. And again, we say that at higher risk for progression are women, those with higher TSH, and those with positive antibodies, TPO antibodies. It's very important to note that the TSH normalizes in about 15 to 65% of those with a single elevated TSH, and this was found in a follow-up of 1 to 6 years. And again, worth to mention that there is a higher likelihood of spontaneous recovery in those patients with a TSH less than 10. So the recommendation is before saying that somebody has SCH, we have to confirm that with a repeated TSH measurement after 2 to 3 months of the first measurement. And again, it's important to mention that the TSH levels vary throughout the day and are highest usually at night. So some colleagues recommend that we should try to measure the repeated TSH at about the same time of the day. And why do we have to diagnose or screen for SCH? Because there is progression to overt hypothyroidism, and because SCH may alter cardiac function, lipid status, and we may possibly have cardiovascular outcomes. We may have altered mood, cognitive function, hypothyroid symptoms. We may have important clinical implications in pregnancy and in childhood. And I'm going to try to go over these problems one by one. And starting from the cardiovascular issues, I'll proceed with the lipid abnormalities that we see in abnormal thyroid levels in hypothyroidism. And as we know, about half of the patients have elevated total cholesterol level, and about 1/3 of the patients with hypothyroidism have high cholesterol and triglyceride level. And as we see here in this graph, the LDL levels increase with increasing hypothyroidism grade. And if you see, in the SCH range, we do have an elevation of the LDL levels, which may cause some cardiovascular problems. From different studies, it was shown that SCH is associated with dyslipidemia, and starting from the Colorado Healthcare study, where they found that the euthyroid patients had a mean cholesterol levels of 216, and the SCH patients had a mean cholesterol level of 224. In the EPIC Norfolk prospective study, there was a significant increase of total cholesterol, LDL, and triglycerides in SCH women only. 2 other meta-analyses showed that there was a beneficial effect of L-thyroxine on lipid levels. The total cholesterol was decreased about 5.5% and the LDL about 7.3%. And this is shown in one of these meta-analyses in this graph. But we have to consider that in these studies, they didn't separate the subgroup with a TSH of less than 10. They included patients with a TSH of 4.8 to 19. But again, they showed a decrease of the total cholesterol and the LDL cholesterol with treatment of L-thyroxine. The same was shown in this study, which divided the patients in 3 groups. The first group is the one with the subclinical hypothyroidism, and again, the L-thyroxine treatment showed that there was a decrease of the total cholesterol and LDL levels. So we may say that SCH can increase the cholesterol levels, can lead to some cardiovascular problems, and that L-thyroxine therapy may be considered as an important decrease in cardiovascular risk favoring treatment in patients with SCH. In terms of other problems with the cardiovascular system, I should say that SCH is associated with LV diastolic dysfunction, reduced resting, and exertional systolic function. There is an association with increased vascular resistance, arterial stiffness, endothelial dysfunction. SCH may act both as an independent risk factor for heart failure and for worsening of heart failure, but this was evident in those only with a TSH of more than 10 MIU per liter. There might be also an association with a significant decrease in insulin sensitivity, which is another risk factor for cardiovascular problems. And there was also in one study recently published a suggestion of improvement of endothelial dysfunction and insulin resistance after levothyroxine treatment. But again, there was no evidence for cases with a TSH of less than 10. In the Big Rotterdam study, which was a cross-sectional study, they included about 1,200 females aged about 69 years old. Of those, 10.8% had elevated TSH, more than 4, and they they studied the incidence of aortic atherosclerosis by measuring the aortic calcification and the incidence of myocardial infarction in these patients. And as we see here, compared to the euthyroid patients, the odds ratio of developing a myocardial infarction and aortic calcification was higher in those with a high TSH and even higher in those who had also positive antibodies. Other cardiovascular risk issues in SCH, which are controversial, in the Wickham study, which also was a big population study, they were able to show no increased cardiac mortality in a 20-year follow-up in these patients. In recent, again, publication of six meta-analysis, there was a suggestion of that cardiovascular risk exists for persons that were below 70 years old. There was no effect on those between 70 and 80 years old, and there was a possibly protective effect of SCH in those who were more than 80 years old, and that was really very important. Another study that comes to add to this, the Leiden 85 study, which followed 600 people with TSH 5 to 10 from age 85 to 89. They showed that without getting any treatment, they showed that this elevation of TSH was associated with longevity and reduced risk of cardiovascular disease and overall mortality. Other cardiovascular issues with SCH, it is controversial that it's associated with elevated blood pressure. There was an interventional study with 56 women with SCH treated for about 18 months, and they showed normalization of systolic and diastolic blood pressure, cholesterol, and homocysteine levels. In a randomized controlled trial, they showed a reduction in carotid edema, media thickness, and improvement of bronchial artery endothelial function after they were treated with L-thyroxine. And in observational data published in BMJ, they showed a protective effect of SCH on the development of atrial fibrillation. So I'm going to move on to the musculoskeletal system. We know that patients with SCH have more often weakness, myalgia, reduced muscle strength. The beneficial effects of thyroxine treatment on strength measurements and cardiovascular, cardiopulmonary exercise performance, they were shown in two studies published in Thyroid and Journal of Endocrinological Investigation. But in large cohort studies, they showed that there was no reduction in functional mobility or capacity in elderly patients with only mild elevations of TSH. But in these patients, and we're talking about patients more than 70 years old, they showed that they were slightly better. In a prospective cohort study, they showed an increased risk of hip fracture in men with SCH, but not in women, and that included 3,500 patients with a median follow-up of 13 years. And in a big study from Norway, including 25,000 patients, prospective study, they showed no association with hip or forearm fracture when these were adjusted for age, BMI, and smoking. We know that our psychiatrists and neurologists ask always for thyroid function tests when they deal with their patients. And we know that in patients with SCH, there is treatment failure for depression. And this is more commonly observed in these patients. But there is conflicting evidence of the association between SCH and cognitive function, dysfunction. It is, though, reasonable to see this patient and have a low threshold for therapy for SCH because sometimes they get better. Probably, we know from some studies that there is mild impairment of declarative memory, working memory, and mood in younger patients with SCH, and that this improves with L-thyroxine treatment. But for those who are more than 65 years old, there is no suggestion of the same benefits. In the very recent meeting in Florida, the International Thyroid Congress and ATA meeting, they showed two studies. One prospective study, which included 9,000 patients, about 65 years of age, and these were enrolled to the already mentioned Rotterdam study. These patients had TFTs and dementia assessment, and in those with a higher TSH, they showed that they had a lower risk for dementia. And these were adjusted again for age and cardiovascular risks, which are risk factors for dementia. And they showed that women showed a lower risk compared to men. In a poster in the same meeting, 35 subjects with dementia had measurements of the levels of the thyroid hormones in the CSF, and they found that there was a link between disease progression and local alterations of thyroid hormone levels. In terms of the goiter and thyroid cancer, we know that SCH is associated with goiter in adults, but there is a stronger association in children. Increasing TSH levels, even within the normal range, if they are up to 5, they are associated with a higher risk of thyroid cancer, and that was shown by the group of Fiore. The same group, in a large study of 28,000 patients, they showed that treatment with L-thyroxine was associated with a lower risk of thyroid cancer. So we may say that SCH may have a role in the genesis of goiter and thyroid cancer. Other clinical implications, in a prospective study from 2013, they showed impaired gastric motility and consecutive symptoms in premenopausal women with SCH. In another study, they showed a dose-dependent relation between TSH levels and non-alcoholic fatty liver diseases in patients with SCH and overt hypothyroidism. We know that there is no strong evidence between SCH and anemia, but 2 randomized controlled trials concluded that addition of L-thyroxine to these patients had a better result on the levels of hemoglobin and ferritin than in those treated with only iron supplementation alone. I would like to say a few things about SCH and pregnancy, because we know that the SCH affects women in their reproductive age, and that we have lower trimester-specific TSH reference ranges during pregnancy, so we found many women having these abnormalities. SCH has been associated with adverse outcomes during pregnancy, and that thyroid hormones are crucial for the normal fetal maturation and brain development. So the acceptable range of TSH in pregnancy is the first trimester up to 2.5, second up to 3, and the third up to 3.5. The clinical implications of SCH, we know that it might cause infertility. It might cause higher rates of placenta abruption, pregnancy loss, gestational hypertension, and severe preeclampsia. There is an increased risk of preterm delivery and neonatal complications, but these have conflicting data on these issues. And it is uncertain if maternal SCH leads to impaired cognitive development in children. So it is controversial if we should universally screen asymptomatic pregnant women in the first trimester, but ATA recommends that we have to check TSH in pregnancy if a woman comes from a moderate to severe iodine deficient area, if she has symptoms, if she has a family or personal history of thyroid disease, type 1 diabetes, history of miscarriage, preterm delivery, head and neck radiation, or morbid obesity. But there is no evidence that screening for isolated hypothyroxemia is indicated, because many of our colleagues give treatment for this problem, and this is not correct. We have to give levothyroxine to keep the TSH within the trimester reference range. And during the first trimester, we should check TSH every 4 to 6 weeks, once in the second and once in the third trimester. After delivery, women who were diagnosed with a TSH of less than 5 and negative antibodies, they should stop the treatment and recheck the TFTs after 6 weeks. So the recommendations in general for screening for asymptomatic patients, if you see here, are different according to the different medical societies and experts groups. So we don't have really the standards what to do. Everything is in controversy. We have to restrict the screening and treatment in high-risk individuals, but should we treat these patients? This is another big question. There is no clear recommendation concerning efficacy and safety of thyroid hormone replacement in SCH. So what we do usually, we individualize the decision on treatment or not, based on what we see, the clinical status of our patient. Most experts, though, and societies suggest treatment if TSH is more than 10. For those between 4.5 and 10, the TSH levels should be monitored every 6 to 12 months, but do we really follow this? When we have patients in our office who went on the website and they found all the symptoms, and they come there and they complain about having the symptoms, sometimes we are forced to treat them. Most recommend to start a low dose of 25 to 50 per day in the elderly and those with cardiac disease, and in a weight-adjusted dose in all others, 1.5 micrograms per kilograms per day. But the risk of overtreatment is about 14 to 21% of people with SCH, and we have to be very careful. If I have time, I'll say a few words about children and subclinical hypothyroidism. In the general population, SCH normalizes in more than 70% of children and adolescents. This is very important. And we know that it's more common, 10 times more common in children with Down syndrome, and they should be screened. In SCH, due to chronic autoimmune thyroiditis in children, thyroid function normalizes in 34% of patients, remains stable in 42%, and worsens in 24% over 4 years follow-up. There is lack of studies that examine the impact of SCH in neuropsychological development in children less than 3 years old. And it's very important to know that SCH in children is not associated with adverse effects on growth or bone health. So the recommendations are to treat infants more than 1 month old with levothyroxine until the age of 3. Because we know that at that point, the brain development is no longer thyroid hormone dependent, and then we try off treatment. If the elevated TSH persists, then we have to do thyroid imaging. In children with SCH, more than 3 years old with negative antibodies, we just have regular monitoring yearly, we don't treat. In those with positive antibodies, we monitor every 6 to 12 months. And there is regular monitoring in children with Down syndrome. There is insufficient evidence to recommend treatment in children with SCH and TSH less than 10. And my conclusion is that SCH is a common disorder that increases with age. The screening and treatment of SCH are still controversial. The level of evidence on the association between SCH and various clinical conditions is not sufficient yet. Treatment of pregnant women and children less than 3 years old with SCH is recommended. Treatment of the elderly should be with caution and may not be needed since, according to what we see in the studies, SCH may have a protective effect, but most physicians individualize the approach until we have stronger evidence. And as I put on this slide, there is no strong evidence for most of the clinical implications of SCH, but only for the elevation of, for those who have a TSH more than 10. So we have to be careful with the treatment until we have more evidence for this issue. And I thank you very much for your attention.